So welcome to all the participants and organizers, and thank you very much for joining the webinar tonight. We extend a special thank you to our partners for organizing this event for tonight. So we've got RAP, which is a Rural Health Advocacy Project. They've basically funded the Zoom platform for tonight. And then Tshemba for providing the CPD registration, and then MRC Wits-Agincourt for finding speakers and facilitating the session tonight. So thank you very much. As RuDASA, our main aim is ensuring access to quality care for especially for rural communities, which birthed the idea of this collaboration in order to ensure that we strengthen bonds and knowledge base for rural practitioners. So I hope tonight is going to be productive and that you can actually draw some new information from this webinar, and that it can open a platform for everyone to continue interacting with each other and, you know, drawing from best practices. Thank you. I hope you enjoy it.
Wonderful. Thank you very much, Lungile. Good evening, everybody. I'm very excited about this webinar. My name is Jacques Dutoy, and I'm one of the doctors working at the MRC Wits Research Unit based in rural Mpumalanga, and very excited for the conversation that we have and the panelists. So just to kick off, just a few housekeeping quickly. You should be able to see each speaker as they start speaking. If you're having issues, please just send them in the chat and we can try and address them. We'd really like this to be as interactive a session as possible, because at the end of the day, the purpose of these webinars is really about trying to create a platform for us to share our experiences, share our difficulties and the challenges, and try and see how we can really just collectively overcome a lot of the challenges that we face in more isolated and rural spaces. So as the speakers are making their presentations, please feel free to throw your comments and your questions into the Q&A box. There should be at the bottom of your screen a small little tab with two little bubbles saying Q&A. Please click on that and type them in. Then only the panelists will be able to see those. If you write them in the chat, everyone will, just so you know. Try not to use patient names while we're doing this. I think we should definitely try and keep confidentiality, so please just use pseudonyms for the names. And then obviously this will be a CPD event, but in order for us to do that, we're going to be using a polling system just to make sure people are here and present throughout the whole talk. So don't worry, you won't get marked down for incorrect answers. Please just throw an answer, and just mainly so that we know you're there. And lastly, at the end of the session, we will have an opportunity where we'd really like you to either, again, in the Q&A forum or in the chat session, please just, if you have topics that you think would be very useful at future webinars, please put those in there, but try and leave those for the end of the talk so that they don't mix up with the questions. And if you need the bathrooms, they should be just down the hall to the right. Great, so without further ado, we are going to start off with Dr. Hans Hendriks. So Dr. Hans Hendriks is a family physician who's been spearheading and the implementation of the Family Medicine Registrar Program at Zithulele since 2016 in the rural Eastern Cape. So he's an undergraduate and postgraduate student from Stellenbosch, and he worked at Ceres for about 10 years before relocating to the Wild Coast. And he really is true to type as a family physician. He enjoys all spheres of medicine, especially obs, surgery, emergency medicine. But outside of work is very involved in the wilderness, from the sea to the hills and mountain biking. So he's well positioned out there. But deep down inside, we all know him as Handyman Hans, often found with a drill. And as you'll see, that DIY spirit finds its way into the hospital and patient care. And I think was quite an inspiration for his bubble CPAP, which he will tell you about. So over to you, Hans.
Thank you, Jacques. Yeah, without further ado, I'm going to just start the talk. Yeah, rural approach to ventilation and how we approach COVID at Zithulele. These pictures is just to demonstrate that it wasn't all bad. We had quite a bit of fun. You'll see the 4x4 mask on the left. with a yeah, it's basically got a snorkel there, and then my son and my daughter, and then we worked in smileys into it. Lots of fun. I think my wife made more than 400 masks in this time, so like we were busy with this. If I just go. So maybe to start with just demographics, who we are and what we do and where we are, and like, are we tertiary, primary? So Zithulele Hospital is situated in the Eastern Cape in the Oliver Tambo district. It's a 146-bed primary district hospital with a population that we serve about 130,000 people. So that's just to give you an idea what we do and how big we are. We've got about 14 doctors working here. So that kind of like just gives you an idea to where you work and where your situation is, like what size we were working in. Let's start off with how did we pick up our COVID cases? And I think it's much the same as everybody was doing. We had obviously gate triage at the hospital. And at our gate, there was security guards were vital. There was a nurse present always. And then our clinical team, either allied health or doctors, everybody pitched in an hour a day or hour a week at least, that two of each of the disciplines were present to help sort through the patient. So it was PUIs was picked up as self-referrals or symptomatic, but basically as we caught them there at the gate, and they fit the criteria, we send them to the COVID tent. That was just like 50 meters away from the gate. There basically we sorted through the patients. They got a more in-depth screen. Patients that didn't look like COVID were sent down to casualty following the old route. If there was COVID suspects, then we would have done the swabs, decided is it inpatient, outpatient. If it was an inpatient management, they went down to the ward. Infrastructure changes was important. The COVID tent was a big change and a huge help. I don't know what we would have done without it. But then, like I think most hospitals, we had to create a dual casualty and ward system for COVID and non-COVID. So the old casualty and the old wards were still functioning, but then we had to swap wards around and create a big enough space to manage the enormous number of COVID cases we were expecting. So was it enormous numbers? It turned out not to be, thank heavens. We projected was more than 100 admissions a day we were expecting at some stage, according to the projections. But in the end, we ended up with only 244 admissions to COVID ward for this time. Of these, 143 tested negative and 4 were inconclusive. 97 were positive. And of the 97, 64 survived and was discharged, but 33 died. Of the 33, 80% died within the first 24 hours. And this we only realized after a while when we started looking at the data. And that then you kind of have to ask yourself, like, is that not, if we wanted to do this better, if heaven forbid we had to do this again, that should be where our focus is. Let me just pick something on the poll so it can go away. Oh, there you go. Okay, so some more stats that the number of positive COVID patients we received from outside hospitals, we got 10 COVID patients early on during the pandemic as it started infiltrating into the Eastern Cape. 10 patients sent from other hospitals that just couldn't cope with their numbers and couldn't isolate and safely keep positive patients. So that was an interesting component. Suddenly from far away, ambulance arrives, delivers a patient to us, 10 of those. The number of patients we did proning for was 11. And this is actually a true number. The physiotherapists kept good data, which is it's not a lot, but I found it very interesting to see how positive the physiotherapy team was about proning. They thought it was just the bee's knees. The question of how many patients did we have to give more than just mask or nasal prongs, and these numbers, I must say, is a bit more of an anecdotal collection of evidence. I went around because we never kept pure data from like who got ventilation of some sort, and I basically spoke to all the doctors involved and asked their numbers and got the average, and this is what we came up with, and I think it's pretty close to the truth. About eight people got bush CPAP, about 3 used the PEEP mask and high flow nasal oxygen, 8, and we had no intubations and referrals. What those are, we will speak of now. So maybe just taking a step back, what did we do before COVID struck? Ventilation at Zithulele basically existed of like, we've got an oxygen bank, unfortunately, with Afrox 50-liter cylinders. There's a picture in the top corner that supplies the hospital. We don't have an oxygen generator, so I think it was 2 or 3 times we ran out of oxygen, and Afrox was called to rush down, and once or twice we actually had to our drivers had to go and fetch more cylinders. So this was a source of great stress during the pandemic, because we were always worried about running out of oxygen. And often if the sister phones you of the patient that's desaturating in the ward, you almost ran to the oxygen bank first, because that was usually the cause. We had one neonatal CPAP machine in our neonatal ward, which obviously we couldn't use for COVID. We had a bubble CPAP for the peds ward, and my beloved Hamilton ventilator. It's an incredible machine. Happened that we never needed it for COVID as such. So how did we deliver oxygen to those in need that needed a bit more? So obviously everybody started off on fresh sea air. We're close to the sea here, so I mean that was for free. And most patients that only needed that went home and used it there. But obviously anybody that needed more were admitted, and first line was usually nasal prongs, and then we would step up to 40% oxygen mask. Quite often the two on top of one another, nasal prongs with the oxygen mask, if you were the doctor were becoming stressed. Non-rebreather mask we never got in time. We've actually now a lot arrived now, but we could never use that. So the next step would have been our bush CPAP, or a PEEP mask, or the high flow nasal oxygen, and these were kind of not. There was no prescription at which one to use first. So it was mostly on doctor's preference, but mostly we started with the bush CPAP, and then we would step up to the others if needed. Like I said, intubation and ventilation was never needed. I can just say that the high flow nasal oxygen during the COVID time, we had one machine, of which you see a picture now. We got it eventually, like last week, 3 more arrived. So we're quite well set now for the future. Next question is probably, so how did we decide to go over from nasal oxygen and face mask to some form of ventilation? The academically correct answer would be blood gases. But I've got to be honest, we don't have a blood gas machine. We've got a machine that we bought ourselves, but we ran out of cartridges and they're so expensive. So we don't have blood gases. So then the next answer would be SATs under 92% and a respiratory rate above 25. That was a prescription. Then you start thinking like, okay, let's step up the ventilation. But I must be honest, patients crashed, and then we usually started running and collected. So, and looking back, this is actually, I think, where we could have made the big difference. That 80% that was circled in previous slide was usually patients that I think we waited a little bit too long, and to rather decide like, if the SAT starts going below 88%, go straight on to the next form. And if I have to do something different, it would probably be that. Just one note that the drawback of high flow nasal oxygen is it uses quite a lot of oxygen. It runs through the bank surprisingly fast, and we ran out of oxygen a couple of times, as I mentioned. Our machines, in theory, they can run up to 60 liters per minute. With what we have available, we got to about 50, 55 liters per minute. Now, just a thought on CPAP for those of you that haven't worked with it yet. Basically, it stands for continuous positive airway pressure. But all it is, it's fancy nasal prongs that's usually giving warm humidified air at a positive end expiratory pressure of 5 to 10 centimeters of water. So it basically just helps you to inflate all the alveoli and keep that basically the absorption of oxygen going better than it would have done without it. But I think the warm humidified part is essential. There's a diagram also. But what we made with the Bush CPAP, and I've got some pictures now to just show you, we got the humidified part, but it wasn't warmed. So the warm part does make a big difference in the fancy machines. So in the picture, you can see what you use for our CPAP, Bush CPAP, and it's basically a normal mask you would find in theater. These ones with a tubular balloon on it that can be inflated is by far the most comfortable because they need to be fitting snugly. At this point, it's very important to mention that if you want to do a high flow nasal oxygen, Bush CPAP, PEEP Mask, or any of these modalities, the patient has to be able to work with you. If it's a confused patient fighting with you, that will not work because they will brush it off all the time. But that being said, if the patient works with you, it's actually very effective. So just a bit more detail. What I do is firstly I just drill 2 holes through the opening, and I run a cable tie. This is the quickest way of making that I found. So I mean, there's many ways to kill a cat. So you just run a cable tie through, and you take the 2 bits of the IC drain, the intercostal drain, the bottle, so that pipe, and then you just take the green pipe that comes with the face mask, then you fit it through the opening, pull the cable tie tight, and then just seal it up with duct tape or isolation tape. And like I said, I don't know if you heard this part, but any good project has to have some duct tape in it, otherwise it's not good enough. So then you sit basically with the final product. So what you've got now is the green part you connect to the oxygen in the wall, preferably to the one running through the water, so you at least humidify the air coming through, but it's not essential. It can go straight into the oxygen nozzle there, and you run it. Okay, let's just say then on the ICD drain, the bottle you fill with enough water so the depth of the pipe is basically the PEEP you're creating. If it's 5 centimeters under the water, it's a 5 centimeter PEEP or more. But you open, as long as the mask is sealing well, you open the oxygen on the wall so that there must be continuous bubbling in the water. Then you know you've got a positive pressure going all the time. And that we found is better than oxygen. So just by doing that, we've helped quite a couple of PCP patients in the past that weren't accepted at tertiary settings and that wasn't doing, we were at the point of intubation with nowhere to go. So this is kind of like an intermediary for us. So I'm open for criticism on this. It's just a trick we tried and it worked relatively well. If there's any questions later on about that. Second last slide is just, I mentioned a PEEP mask. This is something we received just as we started needing it. It came from a company in East London that was a startup company basically making what they call a PEEP device. And it's actually, it seemed to be able to be more effective than the Bush CPAP mask. We tried it, like I mentioned, on 3 patients. It's got a PEEP valve and then an anti-asphyxia valve, which is just like the same valve that's just inverted, so that if the oxygen run out, the patient don't smother, basically. It's got a filter in, which is something we didn't have, and with a bag in, you've got like a very nice reserve. And this mask works actually very well. Some doctors even said they thought it worked better than the high flow nasal oxygen. None of that's obviously proven. This is the 3 things we've done, and I'm open for questions whenever that comes. Thank you.
Wonderful. Thank you so much, Hans. That was really, really interesting and really insightful. So they've just popped up another poll. So if everyone wants to just answer that, and then any questions you may have, please just put them in the Q&A section or in the discussion, and we'll take those. I'll just give you a few seconds for the poll. So while we're waiting as well, so I think let me also just introduce our other panelists, so they can also weigh in before they speak. So also on this call we have Dr. Jeremy Nell, who is a infectious disease specialist working at Helen Joseph Hospital. So he graduated from Wits in 2006, after which he specialized in internal medicine, also at Wits, and also completed his fellowship in infectious diseases. He then was awarded a diploma in tropical medicine and hygiene from the Royal College of Physicians in 2017, and recently completed a fellowship in transplant infectious diseases at the University of North Carolina and Chapel Hill. So he's an active member of the South African HIV Clinician Society, and has also been involved in several guidelines and committees surrounding that, and specifically looking at ARV guidelines, cryptococcal meningitis guidelines, and transplant HIV guidelines. He's a member of the COVID-19 Ministerial Advisory Committee and the National Co-Principal Investigator of the WHO Solidarity Trial, which is seeking to find treatments for COVID-19. So we're very lucky that we have him on the call and for his input into this webinar. Thank you very much for joining us, Dr. Nell. So if you would like to have any comments on that before we hand over to you, and then we can maybe go into some questions.
Oh, yeah, that is quite incredible work. Well done, Hans and your team. That is really phenomenal stuff, and quite humbling. I mean, I think, as you rightly say, that you've saved a bunch of lives through that, and that's a real testimony to what can be achieved with, as you know, as much as it's not always politically correct to say, without a lot of support sometimes. It's often down to the people on the ground rather than the people, who you would normally expect some support from. So that's really incredible, and congrats. I mean, I've learned something. I've taken screenshots to send to our pulmonologists to ask them why they're not doing the same thing here. So that's well done. Yeah, I mean, from my side, it was the COVID experience was we all have a book to write, I'm sure, at the end of this about what COVID has done. I mean, I was lucky enough when it started to be asked to help with some of the training in the WHO, what they call the Afro region. So it's the English-speaking countries throughout Africa, sub-Saharan Africa. And that was in March. It was in Brazzaville there, and really, really helpful, because I think one thing that they were very good at, and they've got a bit of a mixed record in this epidemic, I think, but one thing they were very good at was understanding that this was primarily a respiratory disease, and that countries in the first world would be worried about, can I get the ICU bed for each single patient who needs it? But countries in the middle income group and the low income group would worry, as you guys had to, about simple oxygen, and that really being, the focus of trying to save lives is making sure that people get face mask oxygen or nasal prong oxygen, and then you do what you can for those who need more than that. So that was a kind of a key insight which helped us a lot. As I came back, the curfew started. We had our first patient about a week before. Got told we had to write guidelines for the COVID-19 within 48 hours. So that was a very long 48 hours. And then it kind of hit off. And as you say, we've all had to learn on our feet. I think the hard thing about this epidemic was it was a new epidemic, but it was also a new disease. And that's something that you don't always face together. For example, when we had the Ebola crisis, 5 years before that, we knew everything about Ebola. We just, the scary thing was, could it come here? Whereas this was very hard because we were learning things as we went along. And I think that was a double challenge. You got this torrent of really bad quality evidence for the first few months coming through, and trying to sort of scrape through it and find out what we can do to try and offer the best care without losing our minds, also in terms of, chasing every last rabbit down the rabbit hole. And lots of panic and lots of staff training and PPE issues in terms of, the panic of, would we run out of oxygen? Would we run out of PPE? I sat in a group where we're looking in terms of nationally at oxygen. If we'd had the patients we were predicted to have, we wouldn't have had enough oxygen trucks, for example, in the entire country. We wouldn't have had enough oxygen cylinders in the entire country. And it's things like that, where you start to realize the scale of something is quite different to what you're used to. Endless kind of meetings, very tiring and all that. But I mean, I was, saying since March, basically, and we've all had this to some degree as well. I haven't left the sort of 10K kilometer radius, basically, to get me from my home to the hospital and back. And I think it's a thing that a lot of people have struggled with as well. Through, a lot of colleagues have said as well that they struggle sort of psychologically because it's a quite antisocial disease. I mean, it's literally, we call it social distancing. So you're far away from everyone else. You're not going out to see friends. You're not going out to see family. When you come home to your loved ones, you get worried, am I going to infect them? And so it sort of attacked both those angles. It was very stressful at work, but you didn't get much respite as well in terms of you couldn't travel anywhere, you couldn't go anywhere. So I think this has been a real learning curve for everyone. The numbers, fortunately, as we all know, are well on the way down. It's amazing that as soon as they started coming down, we were about maybe 2 or 3 weeks into that downward trend when we could be sure that it was really coming down. The vibe changed completely, and I'm sure you noticed that as well at your hospitals. We knew we had coped, more or less. And people started relaxing a bit more, all the less fighting. I took leave only at that point because I hadn't taken leave for almost a year at that point. But when I was on leave, something psychologically changed, because when I went to the shops 3 times that week, I almost got into the shops without a mask even, because I just forgot. And I hadn't done that for 6 months. So it was just something, subconsciously I was over this, it was time to move on. But I do think, I'll hand it back to you right now, but I do think that we're unlikely to have a big second wave, which is enormously helpful, I think. The reason is different, I think, to other countries. If you look at Italy and Europe and North America, and ironically, the countries which did really well with their lockdown also, the Southeast Asian countries and New Zealand, the problem there, in a way, it's sort of a double-edged sword, is that whether the lockdown worked or whether you just controlled it very well, you don't have a lot of the population which ever saw this virus the first time. You also don't have a lot of population, to the extent that other coronaviruses may be cross-protective. Also, that's not the sort of country where you get that. And when we're looking here, we've got evidence from Cape Town, Gauteng, Mpumalanga now. We'll get a lot more evidence in the next month. It really is starting to look like a lot of the country had this virus, even if it was asymptomatic. You're looking at numbers, seropositive rates of sort of 30, 40, sometimes 50%, depending on the population you're looking at. And rural areas as well as urban, because we thought maybe it just hit the urban areas where there's much more concentration of people. No, it seems to be everywhere. And again, this is quite provisional. We'll know much more in the next few weeks. But to the extent that's true, that's really good news in a way, because it means that we will not have this huge number of susceptible people in any second wave that will come. I'm sure there'll at some point be a bit of a bump, and we'll probably call it a second wave, but it won't be anything that threatens, I don't think, the hospital infrastructure like the first wave did. Why the models were so far off, I don't know. It's an interesting question, and all the theories, but I'm delighted that they were. Never been so happy to have someone else be wrong, because it meant that we just about managed as a country as well. So yeah, congrats again, Hans and your team. Incredible work. That is really, really impressive. Yeah, thanks, Jacques.
Good. Thanks, Dr. Nam. So I think there were just two interesting questions that were asked as well that I think speak to points there, and especially around this idea of, I suppose, people who weren't admitted who were potentially positive. So Hans, one of the questions was around how many of those PUIs that you actually landed up sending home rather than admitting, because obviously you showed us your admission numbers. Do you know how many were sent home that turned out to be positive? Was it also as low as the inpatient numbers? Do you feel that there was a lot of people actually who were positive in the community just not needing admission?
There was a lot that was positive, but still sent out. And we tried, especially in the beginning, tried to screen, can they self-isolate at home? And if not, we kept them in the hospital initially. But then obviously the hospital became just full, and we had to basically coach them and teach them how to manage it at home. Like, what is the criteria? What's the simple tricks to live with your family without infecting them? Whether it worked well, I don't know. But and I have no idea how much spread there was. But we probably, I don't know. I think probably half of the people we screened was positive, but the asymptomatics all got sent home. Yeah, but there was a lot of positives, and then they got phoned. And I mean, what I found fascinating is how many times you would I never did the phoning myself. My CASA is way too poor for that. But often people were phoned and then they are clearly sitting on a taxi when they answer the phone. And then you just sit like, this is not what we tried. Yeah, so interesting things happened around that.
Sure. And then another question was just around oxygen supplies, because I mean, as you mentioned, high flow is an incredible, I suppose, beast when it comes to using your oxygen. And if you're using 50-liter tanks and it's using such high literage per minute, I think that's quite a problem. What would be your key messages around kind of securing adequate oxygen supplies? I know obviously all district hospitals have their own challenges, and it's different from province to province, but was this quite a battle getting one oxygen to, you know, oxygen regulators and that? And I mean, how did you overcome that?
We had to jump. In the beginning, we saw this as a problem. Oxygen regulators, we had very few. So we quickly had to source some more. I think we were actually fine in the end. We had enough, but we had to jump. Obviously, we don't expect this to happen again, hopefully, not to this extent. So I mean, oxygen, we're actually doing well, but this has told us that there's way cheaper and easier ways, and just getting an oxygen bank with the oxygen, basically make our own. And we start tanking it. And yeah, so we're actually looking into getting the money to get a permanent and not be dependent on Afrox. I mean, next time diesel is going to be so expensive, they're not going to want to bring it here, and like, what's going to happen then? So there's a long chain when you start working with individual cylinders that can go wrong compared to when you've got your own concentrator.
Great. And then one final question, I think, before we maybe move on to the case, was I know in this area at Zithulele, for instance, there was quite a delay, I suppose, in some of the turnaround times on the tests, and a lot of patients were managed as under investigation before we actually had a diagnosis. But again, using those criteria of being mild, the SATs were fine, they looked okay, they were sent home, and quite a few of them seemed to decompensate at home. And obviously, the more you go into rural areas, obviously it's sometimes more difficult for them to get back to hospital. I mean, was that an issue that you encountered quite a lot? And was there any way of getting around that with patients going home and then suddenly desaturating or coming in? Is that maybe why there was such a high rate of early demises? Or were they all fresh? Yeah.
I think all of them were fresh. Because we work in rural, we go from the premise like the patient can't come back again. If there's any doubt, we rather keep the patient. So we had a very low threshold to admit. I hope to think that very few of them were screened, went home, came back. I can't think of a couple of cases, but it was definitely not the norm. Usually they came in when they were sick, they were very sick, we admitted. I hope that answers.
Great. No, that's great. Yeah, I suppose every place will be different, but it's an interesting idea, as you say, in rural areas to take that into consideration when sending people home. I suppose at Zithulele, I know they often have the mantra, you know, one of the questions you should always ask your patient is, how did you get here today? And I think that gives a lot of perspective as to how they're going to get back to you. Great. So I think let's go into the case, and then we can obviously continue discussion afterwards. So I just want to introduce Dr. Joseph John. He's a graduate of Walter Sisulu University in Umtata, where he also performed his internship at Nelson Mandela Academic Hospital. And this year arrived as a new fresh ComServe into Zithulele Hospital in the midst of COVID. So I must say it must be a very interesting time to be doing ComServe, and I'm sure it's definitely challenging your practice and really aging you beyond your years quickly. So we are really keen to hear your case. The floor is yours.
Okay, good evening, everyone. So this is the COVID case that we chose to present today. Just some background. So this happened in the beginning of July. So we were still learning a lot about COVID, and we weren't sure exactly how to go about every case. We're learning basically as the more cases we saw, the more we learned about how we could do things differently. So we chose this case because this was our longest admission. He stayed for 41 days, and we were happy enough to discharge him home. So it's quite an interesting case, and I hope you'll enjoy. So, okay, let's start. Okay. So day one, he presented on the 9th of July. He was a 47-year-old male, RVD negative, known hypertensive and epileptic on treatment. And he had actually been diagnosed with diabetes mellitus about 5 days prior to this presentation. He was then managed as an outpatient and discharged on metformin. So he presented to us on the 9th around 16:45, just before we were about closing up to go home. He came in with a 2-day history of shortness of breath, loss of energy, and change in consciousness. So I happened to be working in COVID during that period. So I was like, okay, he needs to get to the ward immediately. We rushed him to the ward. We did the initial vitals, and on arrival, his blood glucose was recorded as high. We don't have a blood gas machine, but on urine dipstick, his ketones were 3+. Saturation at the time was 54% on room air. Blood pressure was 138/88 with a high pulse and a high respiratory rate. So he was really restless. He was severely distressed and quite, he was just tossing and turning. So based on these initial picture that we got, we assessed him as DKA. And actually during this period, we had been talking about in the morning meeting about how we heard in the cities that a lot of COVID patients are presenting in DKA. So this was like on my radar at the time. Like anyone with a high sugar, we're like, oh, we should probably swab this sort of patient. So as soon as he came, and we assessed him as DKA now, and immediately we're like, okay, possibly precipitated by COVID. So should we probably take him to the COVID ward? So our acute management, so we resuscitated him using our DKA protocol, but obviously, like you saw, he was desaturating terribly. So we used Hans's Bush CPAP. So I made a quick call, like Hans came up with the Bush CPAP, and we actually put nasal prongs as well. So it was like our version of double oxygen. And then by that time we had heard about the other sort of standard protocol, you could call it, of managing COVID patients, or PUIs at the time. So we put him on IV antibiotics because we weren't sure if the DKA was precipitated by an infection. So ceftriaxone and azithromycin. We did bloods, but our lab, we don't have lab services after hours, so we knew we'd only get the results the next day, but we sent it to the lab anyway. We did a FPCA, UNEs, and CRP. We put him on steroids. So at the time, we didn't have access to dexamethasone just because a pharmacy had closed at the time. So we initially just gave him some hydrocortisone. We put him on Clexane prophylactically, 40 milligrams, put him on Panado, and then we made sure to put him on his other chronic medication that he already had, which was the hypertension medication and the epilepsy medication. So funny enough, that morning, we had started hearing little murmurs about pronation, what this was. So like one of our physios came to morning meeting and was like, oh, there's this thing called pronation. And like, I mean, I've only read about it. I've never actually done it on a patient at that point. So I remember asking her after the morning meeting, oh, so what exactly do I just put them on their tummy? Like what happens, how long, And then she was actually like, oh no, I'm going to do a presentation next week, but yeah, that's basically what you have to do, and it helps with the breathing. So I'm like, oh, okay, cool. So we put him on this double CPAP, but his saturation was just not going up. It was remaining in the low 50s and was stressing a bit. So I was like, maybe let's try this pronation thing that we've been hearing a lot about. So we literally asked him, we're like, Tata, please try lie on your side. And obviously initially he didn't want to do that, but he listened to us. And we initially got him on his left side, and then eventually onto his tummy. And I could not believe it. The SATS monitor went from 54 to 75, just like that, in a matter of seconds. I remember taking a picture. I was like, oh my God, this is real. Like I took a picture and I sent it to my clinical manager at the time, Ben. I was like, oh my God, this pronation thing is amazing. We need to really look into it. But yeah, we did that, and we basically kept him on that. We were monitoring his glucose and everything. That was the acute management that we did. So in the first 24 hours, so 12 hours after his admission, he had no ketones in the urine. So ideally we would want to use a blood gas and check but we were using the urine. So around 4 a.m. he had no ketones in the urine. So we had taken him, then we were just monitoring his glucose 4 hourly and his urine as well. And we were only able to do the COVID swab the next day due to lab services and because it needs to be couriered. So we did the COVID swab the next day. We managed to get dexamethasone. So that too, we had recently just heard about it. So we put him on dexamethasone IV 6 milligram for 10 days. And these were the admission bloods that we got. So as you can see, it's a massive CRP of 654. And he had a bit of an acute kidney injury that we had seen. So we put him on fluids, and in the subsequent 2 weeks, his saturation had improved. We kept him on the double oxygen with the Bush CPAP and the nasal pumps for about 10 days, and then he was able to move on to oxygen with face mask alone. But his saturation at this point would always hover between 60 and 75%. We could never really get it above that. And as soon as you take the oxygen off, it would just drop down to really low numbers. So that was one thing that we struggled on. So we kept him on the double oxygen, like I said, for 10 days, and then eventually we were able to move. He started slowly going up, and we were able to get him to sats above 90 just on the face mask, and his acute kidney injury had also resolved. Okay, so now Dave, so like I told you in the beginning, he was here for 41 days, so I'll just mention some of the highlights. So on day 14, he developed a temperature spike, actually. And he quickly, all of a sudden, got a high temperature. His white cell count had gone up from 8 to 15. His platelets were 675. So since the admission, his CRP was on a downward trend, but all of a sudden that day it went up. It went up again. And we did a chest X-ray at the time. Unfortunately, we don't have our X-ray department. We can't get printouts, and they don't store it for long. So we couldn't actually access a lot of his initial X-rays. But at the time, he'd had widespread infiltrates bilaterally. So we're thinking, oh, is this some sort of pneumonia that he's getting now? Because he was getting better, and all of a sudden, maybe the hospital acquired. So we put him on IV augmentin for 5 days, and luckily he actually got better, and he didn't. All the parameters came down. And so, like I said, we've been talking about pronation and everything of the physio. So we were talking a lot with the physios, but at that point, our physio department was not really, they hadn't made a decision of coming into COVID ward at the time because they needed to be strict protocols about how we were going to do that to keep everyone safe. And obviously the same physio department has to treat other normal patients who don't have COVID. So it was infection risk. So only on day 14, at that point, were the physio actually hands-on involved. So some of the goals that physio had with COVID patients in general were deep breathing exercises, pronation, to basically try to get the patient to sit up on the bed and try to get him off the bed and onto the chair next to the bed, start some ambulation and wean off the oxygen. And as you can imagine, these patients mostly in COVID, if they're in the ward, they need oxygen. So they're not getting out of their beds. And so they do lose a lot of their strength. So we need to make sure that that isn't a side effect of being admitted. So they'd also make sure to keep an eye on their lower limb strength and making sure. So that's some of the goals. And now on day 26, our physio department actually, they're really amazing. They were able to make our own PEEP bottle. So basically they used, I'll show you a picture soon. They used a normal saline, a sterile water bottle with the tube. And so basically they'd instruct the patient to take a deep breath in and then breathe out as slow as possible, but into the pipe. So that to basically, and take as long as possible. And that will help increase lung volume. And so that was some of the things that they were doing. And so at this point, physio was heavily involved, and we were really relying on them to basically get some improvement in him, because we were seeing some sort of like a stagnant progression, like he wasn't really getting that much better. And then I started to suspect, like, does he have some sort of chronic respiratory failure, maybe because of COVID, So like, will he actually get better, or will he be oxygen dependent for life after this, and we didn't really have much data about this. So we thought about discussing with our referral hospital for CT chest, maybe to see what is the condition of the lungs. So we had started discussing, but because he was still on oxygen at the time, it was very difficult to get a CT chest because there's a lot of politics around that. And but we had started discussions with them. So this is a picture of our PEEP bottle. As you can see, it has to be returned to therapy because we don't have a lot of this. And basically our physios are running around looking for these bottles in the hospital. And they try sterilize it and hopefully you can use it for the next patient. So this was always on his bedside and he can do it. He'd do it when they arrive and also whenever he could during the day. And I really think this made a huge difference in his improvement. Then this is a picture. I was looking through my phone to see if I'd taken any pictures. It's not a great picture and not a great X-ray either. But this is one of his this is a picture of an X-ray that was taken on the 10th of August. So it's almost about a month later. As you can see, that we saw some. So this is also part of the reason why I was thinking of a chronic respiratory failure that he might be having, because there was a lot of fibrotic changes, as you can see. So it's not a great X-ray. It's not because it wasn't done in inspiration. But you can see a lot more fibrosis on the left side compared to the right. So this was quite worrying, and that's why we were hoping for CT chest to probably and input from the pulmonology side to comment and basically help us with that assessment. Then now on day 34, which is the 12th of August, we saw our biggest improvement. We started seeing saturation 91% off oxygen. Also, I must mention, so during this time, we had tried to keep him on steroids. So we had switched, we had tried to keep him on prednisone during this time and Panado. So saturation had improved 91% of oxygen. We never thought we'd see this day because we were like, at one point, we're like, how long are we going to keep him here? Because it's been a month now. Is he going to be here forever? Like, you know, and as it is, we can't get oxygen for the hospital. Is how are we going to get oxygen for him to take home? So his sats got up, and he, like Dr. Nell mentioned, like this is a very like sad period in anyone's life, just being during here in lockdown. So you can only imagine being stuck in a ward, in the positive ward, for this long, not seeing family because there's no visitors, and people around him. He was even saying at one point, he's like, you know, I actually didn't get to meet the gentleman across me because he passed away too soon, you know, and if he did make a friend, sometimes the friend got discharged or the friend passed away. So he was quite down, and often we'd find that we were more happy about his improvement than he was. And but so this is the first time. So slowly he had gotten from the bed to the chair, and then he could stand up, then he could go to the bathroom with assistance. And then this was the first day, after 34 days is when he stepped out for the first time. And I know physios can vouch for this, he was so happy. He was smiling, he was chatting, and I think just seeing the sun, you know, and I think I remember the physios were saying like, he was like, he's like, yo, that's when he was like so grateful for us. He's like, you guys are amazing, you know, thanks for caring so much about me. And I think just engaging and having someone to talk to outside and not just ask him, are you breathing okay? And, you know, are you using a PEEP bottle? So just having a normal conversation, sitting out in the sun and being a normal person made a big difference as well. So that was a very happy day for us. And then finally discharge on day 41. On this day, his chest was sounding great. He was ambulating comfortably. He wasn't. So because throughout, even when the physios were doing exercises, he'd always desaturate during the exercise and then he'd have to stop because he'd get really dyspneic. But that was the whole point of trying to wean him off and basically improve his endurance throughout. And at day 41, he was able to finally move around comfortably. His vitals were fine. His sats were 99% on room air. At this point, we had managed his sugars on actrophane, so on insulin, and we had tried to teach him how to do it himself, so that when he gets home, he's comfortable, because he had just been diagnosed just before this whole thing happened, and he obviously did not know how to do that. And then he was sent home on medication with the review date. Funny enough, yesterday was his review date, so it was really like great timing. I saw him yesterday, and he actually came for physio, and then I walked in. I'm like, hey, I'm so happy to see you. And I'm like, you know, I'm talking, how are you doing? And he's like, oh no, I'm so happy now. I can walk around. I don't get short of breath, and he's not coughing anymore. And I was like, oh, and I'm so happy to see him. And then I'm like, hey, do you remember me? And he goes, Not really, hey, not really. So that is like quite disappointing. But then I'm blaming it on all the hypoxia that he had. He was probably So he's like, no, I couldn't see properly that time. But yeah, like, I'm sort of remember your face. I'm like, oh, okay, it's all right, it's all right. I'm just glad to see you today. So I sort of like had to reintroduce myself 41 days and another month later. So this is a picture of him leaving our hospital. So he actually consented this picture. He was really happy because he was quite stressed because so many people are passing away around him. He was always worried about, would it be him? Would he actually be able to go back home? So this is a very big moment. Like, I remember we were so happy when this news spread, like he's got discharged. We were like, wow, he's finally, and we're like so happy. We're like, did you make sure he got his number? Because I want to phone him to make sure he's okay, So this is him leaving. Back. That's our presentation. Thank you.
Wow, that's an incredible case. Thank you so much for sharing that for us. I feel like there's a lot of really interesting key take-home points that we can take from that. I'd really be keen to get Dr. Null's input on that. I just am aware that we have popped onto the hour mark, so I don't know if there's another poll that needs to be asked, just so that those wanting the CPD points have attended their hour, and then we can maybe go into Dr. Null. So I don't know if Andy wants to pop that poll up, and then Dr. Null.
Looks like poll might be at the end.
Okay, great. Okay, that's fine. Okay, so Dr. Null, over to you.
Yeah, again, what a great case. Thank you. I mean, and well done. It's incredible dedication, and nice that it had a good outcome. And I think I'm very pleased he was grateful, even if he didn't know quite who to. I think it's hard, though, to be fair, to recognize people. But I think that's great. I mean, so I was jotting down some things as you went in terms of, almost jump off points. So, I mean, I think, he's had a great response because of the excellent management. So I think, initially, just in terms of, almost learning points for other people, but I mean, not for you guys, you've nailed it, was that, you assessed him as a TKA correctly, and he had SATs of 54. So as you rightly said, then it means it's not just a TKA, right? Because TKA would be acidotic, it shouldn't affect your PO too much, or your SATs. And so that, as you rightly said, and something profoundly wrong. I mean, it's not nowhere even close to normal, with his respiratory rate. So one of our big concerns early when we were trying to train people was to not get fixated by COVID and to consider other diagnoses too, which you did. And that's really important because, we don't want people dying of community-acquired pneumonias because their doctor only thought of COVID. So you're absolutely right. You would give antibiotics empirically upfront. You can't not, because you don't know it's COVID until you have the result. Interestingly, the rate of co-infection is pretty low with COVID, well into the sort of less than 5% figures. So when you do have a COVID result, it's often, it depends on what how you look at the individual patient, but it's often then okay to stop the other antibiotics if it's COVID positive. But then again, using your head, obviously, as you have done, so if it was a low-bar pneumonia or if there was some other reason, then clearly you'd continue antibiotics. The antibiotics continue, so, we want something for community-acquired bugs. We did, in the guidelines, say to add something for atypicals, or something like azithromycin. We see so little of it, though, in the country, and it's difficult to get, but as long as you're mainly covering the big ones to cover the community-acquired bugs. Interestingly, influenza in any other year, this would be a big consideration here, because bilateral infiltrates viral pneumonia looks identical in the beginning. But you may know this already, but we've basically not had influenza this year because of all the non-pharmaceutical interventions. So it's all the hand hygiene, the social distancing, the masks. There was a little bit of influenza in the Cape in March. It disappeared in the entire country. NICD did surveillance throughout the country. So it's not every hospital, but they've picked up, it's like 20 hospitals, but the bigger hospitals, the referral hospitals, they picked up one case. In the whole of Gauteng, I know of one other one in private. It's basically not there, which is incredible. But in any other year, we're worrying, should we give this person Tamiflu or oseltamivir if it's around, and of course may not be around because it's not even an EDL drug. But fortunately, we didn't have to do it this year. The steroids, you mentioned you didn't have the dexamethasone and the night, and you gave another one. So we think that's probably fine, as you said. The trial from recovery, the recovery trial showed dexamethasone because that's what they were using. In fact, even then, they used other steroids for pregnant ladies. And Subsequent to that, now with WHO coming out, looking at all the kind of trials with steroids, doesn't seem to be much of a difference between the steroids. So it's really up to you as long as the dose is right. So obviously there's a steroid equivalence. So if you're using 6 milligrams of dexamethasone, if you want to use PRED, you choose the right dose of PRED, you know, so that it's equivalent, which is in this case 40. If you use hydrocortisone, it equals 160 milligrams. So you do something like 53 times a day or 100 twice a day, because it's very difficult to do 80 twice a day. That's, you know, in terms of the vials. But yeah, so, and then the duration is a really interesting question. So in recovery trial, they did 10 days and that was it. And that was the protocol. They stopped no matter what the patient was doing at 10 days. You could stop early in recovery. So, you know, if the patient recovers and was ready to go home, I think we can be pretty confident you wouldn't want to keep them just for the steroids. You know, they could go home and either continue on prednisone or just stop. But the other side is difficult. What if they don't get better at 10 days? You know, and that's a really difficult question to answer because we don't know. I mean, there isn't the evidence for that. I think the general consensus, but remember that this is a bit of a guess, you know, is that if they're still not well and you're sure that it's COVID at this point, not something else that's developed, then it's probably still being driven by inflammation. So in other words, it's probably good to continue them a bit longer, which is what you did, and you had a great result. It's unknown. I mean, we really don't know. Maybe some trial will come up and show that it's a really bad idea, but I think I agree with what you've done. I would have done the same. But it's unknown. So in 10 days, definitely. More than 10 days, maybe. And I think you'd be guided by the patient there. The one thing steroids do is they prevent the body from clearing the virus as quick. So we know that people shed the virus longer. But the good news is at that point, 10 days in after you've already required dexamethasone, so you're already probably 2 weeks or more into the disease, probably 3 weeks, the viral replication is very low there. So it's unlikely steroids are going to cause much harm in terms of the virus late on. The danger early, because initially, remember, WHO and even our national guidelines were advising not to give steroids up front. And that was because of these other viruses like SARS and MERS and even influenza, where the viral load peaks early. Peaks late rather than COVID, where it peaks early. And so when people were getting into trouble, then people were adding steroids at that point for these other viruses. And it was getting worse. In fact, steroids were associated with more harm from flu, more harm from MERS, more harm from SARS, the first SARS. Whereas COVID, the virus peaks early, so probably later on when you really want to give the steroids, it's not much of a problem. And I mean, it was a real turn up for the books, you know, in terms of, it was a real surprise, the result, but thankfully it saved lots of lives. In terms of DKA, yeah, fascinating. Another thing that we've known, I mean, we don't know enough about this virus. It's certainly associated with hyperglycemia. Initially, you know, when we first started seeing it, we thought, well, you know, maybe it's just a bad infection. You know, any infection will be associated with hyperglycemia, but it's not that. It's more than that. No one's entirely sure. I mean, there are receptors for this virus in the beta cells of the pancreas, which produces insulin, and it's likely that the pancreas gets infected. And, you know, but whether that's what's happening to drive this, I'm not sure. But we certainly feel like we've unmasked the population's diabetics, you know, in this COVID epidemic. Now, you know, I don't think we'll be diagnosing anyone with new diabetes for the next year, probably, because they're all now, you know, COVID drew them out of the water. And you're right, and it becomes very hard. It's hard to control their sugars. They're often very difficult, harder than normal to get the sugars down. And then you're giving them steroids often, which pushes up your sugars even further. So it's difficult. People have developed whole new protocols in the Western Cape and other places to try and almost increase the insulin that you'd give. But then if it's a newly diagnosed patient, it's difficult because the dose to control them now might not be the dose to control them in 2 weeks' time, you know, when they're over this. So it's something to watch. And the consensus from the endocrinologists I speak to is that, you know, there's obviously variations, but the really bad ones, they actually think with time they'll be able to decrease the insulin each visit, basically. And see, so it's certainly something to watch out for. I mean, we don't know enough to know to give a good recommendation, but that's something. And then, yeah, I think you mentioned about the you know, this kind of almost post-COVID lung disease. So that is something. It's not. We know from other viruses that sometimes this happens. We know from PCP, PJP, that this happens. You know, at some point the inflammation transitions to fibrosis, and then, you know, a really sort of chronic and refractory lung disease. I think the key thing there is to make sure it's not something else, and the something else that often gets missed is a pulmonary embolism, because we know with COVID that that's strongly associated, again, for reasons we don't know entirely, probably because it affects the vasculature directly, this disease. But we know it's associated with thrombotic risk in terms of venous thrombosis, so DVTs, PEs, things like that, and also even arterial thrombosis, strokes, heart attacks, and that, but particularly the venous side. And it's in proportion to the severity. So the people with mild disease don't really get it. The people you hospitalize, some of them get it. The people who need CPAP and ICU in place, ideally in that, there's a lot of DVTs that happen, up to a third in some of the series. So that's one thing just to consider in terms of the patient's not getting better. And obviously, as you know, it's a very difficult diagnosis to make because, you know, without a CTPA or something like that, you know, it's often, but it's nothing, no harm initially in going empirically if that's the worry. But I think in your case, I mean, it clearly wasn't. You know, he was just slow to get better, but it was a sort of linear progression to get better. I mean, is that fair to say? Like, it was each week was better than the last week.
Yeah, slow, but it took time.
Yeah. So I think that's kind of more the history you'd get if it was just taking a long time to get better, rather than, you know, he was getting better and then he suddenly got worse. But it's a real hassle. I mean, we had even a doctor who had pretty moderate COVID, felt a bit sick, didn't require oxygen. Just found when she came back to work 10 days later, she just was battling on the uphills in the hospital. Baragwanath Hospital. So if you know it, you walk for miles in Baragwanath Hospital to get one ward to the next. And she just wasn't coping. And she went and got a scan. Eventually, she had about 15, 16 different PEs identified, you know, small peripheral. So it happens. And it's something to consider about these guys that don't get better as well. But, you know, the role of PEEP, I think exactly as you said, is probably a very good thing in this guy. You know, just keep getting him, you know, pushing to him to get that lung better. And I think maybe that plus, you know, really good care in general, plus some steroids longer, you know, who knows what the dominant thing was, but he's had a really good outcome. And I'm very pleased he was grateful, even if he wasn't quite sure to. But it really is a really nice case from that perspective to show. And there's, yeah, it's kind of a case that's got almost everything in terms of this disease. It's going, you know, it shows the whole spectrum more or less, you know, in terms of things the patient needs. But yeah, I think, I mean, I can stop there and we can open it up to the floor. But I think that's, again, it's well done. A really, really nice case and a good example to show to everyone else.
Thank you.
Sure, that was really interesting. Thank you, Dr. Nel. Just so some of the questions that I see have come up, please, everyone still on the chat, please do ask questions in here and we'll send them through to the panelists. One of them was, what other therapies were available to you to treat your COVID patients in the rural setting? Obviously, steroids and anticoagulants have been mentioned now, but would you say that oxygen was the biggest contributor? Did you see a big difference with the use of, I suppose, the steroids and the anticoagulation? Did you see many PEs? Were you treating them quite aggressively or proactively?
Do you guys want to take it or yeah?
I think they might be frozen.
Might be frozen. Okay. I can answer from my side, and let's see. Hopefully, they come back quick. So, in terms of they're there. All right, you guys are back. Thankfully, you can save me. Are you okay to answer that question about the therapies available to you?
We didn't get the question.
It's in the. Oh, sorry. It's in the Q&A. What other therapies were available to treat your COVID patients, like steroids, anticoagulants, etc., or would you say the oxygen method was the biggest contributor?
I think definitely the physio, I think it's a combination of everything. But I think we were quite, I told you, it took 14 days for physio to get on board. And I feel like just based on the improvement that happened after chest physio got on board, I feel that's probably what made a bigger difference. Because I feel like by that point, we had gotten the DK under control. He had gotten steroids on board. Medically, we had done, almost followed the book, you could say, but we just needed that extra something, and I feel like that's when physio came in and they really pushed it. Yeah, so I think physio was definitely up there.
Great. And then another question was also, did he have equivalent of ICU attention in terms of what was the nursing situation? Did you have nursing 24/7? Were there dedicated nurses, or how did you manage him like that?
So initially, obviously, while he was in DKA, we didn't have a lot of admissions at the time, luckily. So I was like, okay, this is our main patient, this is our ICU patient, you could say. So we need to make sure we have someone dedicated to him, and then, the other nurses can help out. But after that, the rest of the time, he was in the normal positive ward. He didn't get any special attention. He was treated like any other of the patient, any one of the other patients. So I wouldn't say he didn't have a dedicated nurse after that the rest of the stay. Just that initial acute management, obviously, whoever is really sick, we try to make sure that someone is responsible for the care. And we have doctors working during the day and night, so we'd always hand over to the doctor as well to go and check on and make sure, please go have a look, make sure he's still getting his insulin, or have a look at the vitals. Is there anything that needs to be changed? So there's always a doctor and a nurse basically involved in the care.
Can I just think we were given a couple of COVID nurses that was junior nurses with no previous training that went into this ward.
Yeah.
I mean, to expect them to manage a DKA is actually would be considered ridiculous, but they were the guys managing this patient, and with great enthusiasm. So it was actually incredible to see how much they can learn.
Yeah.
And they did so well. Yeah.
I remember on day one, I was like, okay, this is a DKA patient. And one of those nurses was like, what is DKA? Should I go fetch it? So that's the level that we started at. Then I was like, what's the diagnosis? Literally, but they were all like so enthusiastic. I was like, okay, let me do the dipstick. They're like, no, I'll do it, So they were very enthusiastic. So literally, if you wrote down instructions, they followed it like perfectly. And now they really, really they're amazing. So, and we're hoping to keep them.
Well, yeah, I think you should hang on to them. So this question I think is directed both to Dr. Nel and to the Zithulele team. There's a bit of concern around the dangers of CPAP relating to staff, because I know that some reports have spoken about it being an aerosol generating procedure. I don't know if Dr. Nel, you'd want to speak to that maybe, but also linking to Zithulele, I mean, would a bush CPAP, would we consider that to also be a aerosol generating procedure? And how can we look after the staff using these different modalities?
Yeah, so maybe I would just kick it off with that. So in terms of the risk to staff, it's probably overplayed. And what I mean by that is that, with CPAP, if you have a good seal, you're not getting much out. I mean, that's how it's working. So to the degree that the seal is good, you are in fact in some of the trials getting far less aerosols and droplets being produced than a normal oxygen mask with CPAP. So even though the flow of oxygen is higher, you've got a much better seal. So that's the one bit. The other bit is that there's increasing controversy in general about this concept of aerosol generating procedures. The WHO has attached it, and so are our guidelines. So it's definitely, we've all said the same line, but a lot of the respiratory kind of physiologists and that are actually, we heard from them last week saying that, in fact, there's no evidence that the aerosol generating procedures even generate more aerosols than normal. So I think, it is a consideration. For me, and certainly our guidelines would have said, please wear the appropriate PPE around that, and that would include ideally an N95 mask to prevent the aerosols and some sort of protection for the eyes too. I will say though that it's probably not as bad as people think about. And so it's less of a concern now than people had maybe a few months ago. I don't know, what was your guys' experience, Hans, at your hospital? How did you handle it?
So whenever we were using like the bush CPAP or any sort of CPAP, they were always in a positive ward, or we tried to keep them in a separate ward. So, like for example, this patient was in a PUI ward at the time initially. So there wasn't too much we could do because we don't have a lot of infrastructure to separate each patient. But we always tried to, if we could, isolate them. And obviously the nurses going in and out had full PPE. So there was never that sort of risk involved. So that's what we tried to do.
Great. And I just noted in time, we have, it says that it might cut off at 8 o'clock on the dot. So we just want to get one more question through, and then I think we'll start wrapping up. But there was a question just around, obviously his SATs were incredibly low, you mentioned, and one of the questions was around, was he discussed with an ICU? Would they have considered him? I know a lot of the isolated rural hospitals don't always get that chance, but could you maybe explain that situation?
So we actually didn't discuss at the time, because I know it was a time when he came when it was really peaking in our district. So we knew about the situation at our referral hospital. It was going to be close to impossible to get him in because they couldn't deal with the local number of patients coming in into the tertiary center at the time. So we were aware through our managers of the situation on the other side. So that's why we tried to do as much as we could on this side. And then if really we were struggling, so I think because of the Bush CPAP, we had such a good response in the beginning, and there was that progression, and he was getting better in the first couple of days already. We didn't consider it at the time.
Great. Thanks very much. I feel quite inspired by this, that I feel that sometimes we feel that there's not a lot we can do, especially if we don't have all the equipment. But I think you guys are really just leading the way and showing that we can do quite a lot with quite a little. Yeah, thank you for that. And so I'll hand over to Lungile if you'd like to make some closing remarks. Lungile, you're muted.
Thank you, Jacques. So I'd really love some feedback from our participants, especially questions going forward. So any questions that you would like us to address, any topics for future webinars. But I would just really love to thank everyone for their continued efforts into bringing quality care to rural communities. And especially, I mean, we've heard the story from Zithulele Hospital, just how difficult things can get sometimes. But well done for all the hard work that you continue to put into these rural communities each and every day. May God bless you for that. And I do hope that everyone stays healthy during this difficult time, and especially looking after your emotional state. I'd like to extend a special to Joseph, Hans, Jeremy, Andy, Steph, and Jacques. So Steph is the RuDASA admin person. She's keeping off the radar tonight, but she's part of the, she keeps sending us these keep in check messages. So thank you so much, Steph. Jacques, thank you for housekeeping. We did need the loo and we used it. It's quite clean. Thank you for maintaining it at such high standards. So for everyone, thank you and good night.